Good morning, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's live discussion. Without further delay, I would like to invite our speaker for today's session. He is Dr. Anirban Sinha, sir. And let me share some of the achievement of sir. Sir has done MBBS, MD, DM in Endocrinology, FACE, Associate Professor at the Department of Endocrinology at Medical College, Kolkata, and visiting consultant at Amri Hospital, Chairman of Ethics Committee, Central Hospital, SER. And today he is going to discuss on a very important topic, that is silent glucose storm, surprising diabetes revelation. So by taking not much time, I would like to invite sir and hand over this session to sir. So the stage Ethics Committee, Central Hospital, SER. Sir, the stage is yours. You can proceed from here. Topic that is
Yes. Hello. Good morning, everyone. Can you just see the screen maybe if possible? So today is a discussion on GAD 65 positivity boys with pancreatic calcification. So we all know GAD positivity is why the slides are not seen. I don't know. That's disturbing. I can't see anything.
Is it visible, sir? I have shared from my. Hello. Are you able to see the slides?
That is not what. Okay. I will read out the slides from my.
Okay, fine, sir, fine. I'm in the introduction part, sir. We are in the introduction part. You will say
Sure,
next.
go
I
on.
will.
So what I want to say is that diabetes commonly seen is type 1 or type 2. We all know of. That is young onset with insulin depleted, islet depleted, and type 2 is mostly yeah, insulin resistant. So these two are the main disease, but interestingly, type 3C diabetes is also common in the patients of chronic pancreatitis. Sometimes we commonly miss that point because chronic pancreatitis is very vague presentation. Sometimes patients only present with pain, sometimes only with irregular bowel habits, sometimes with fat diarrhea, and sometimes just the weight loss. So it is with the most common pathophysiology. It's a bystander injury to the islets resulting from the fibrosis and intrapancreatic inflammation. And I don't know what the sound is. My internet is disturbing very much. Sorry for that. So hepatic insulin resistance due to the pancreatic polypeptide deficiency. That is another way of having the insulin resistance independent of type 2 diabetes. That is peripheral insulin resistance and alter the insulin response is of patients of chronic pancreatitis. Because in the chronic pancreatitis, insulin response is disturbed. Second point is emerging data suggests that autoimmune mechanism playing a role in the pathogenesis, and hence we report a case of chronic young boy new onset diabetes with positive pancreatic autoantibodies, extensive pancreatic calcification, and the 11 years of age, and then 38, and he revealed that negative anti-ILS antibodies, anti-IA2, but strongly positive anti-GAD antibody that is quite high. That is 219 injection unit per ml. Normally is less than 10. Given the rapid onset of the disease of the child, it was considered as type 1 diabetes because the patient becomes insulin-dependent, requirement of insulin is increasing, and the patient has very high blood glucose at presentation. So this presentation actually makes the patient concerned. So So patient steatorrhea, features of malabsorption or chest infection. That is important. Again, many of the patients actually do not have it. Family history, father diagnosed of diabetic at the age of 27, that is quite early age. Again, we need to exclude the MODY or maturity onset diabetes in this patient with the previous history of the latter passed at the age of quite early age of 37. This is we are talking about father. So this is the presentation of the patient. Hemodynamically unstable, and patient at presentation, the height is in the 10th percentile, weight is in 25th percentile. Patient is lean, BMI is actually low, 15.7. That is pretty low. That is -1 SD compared to the age. Examination also revealed there is no signs of acanthosis, insulin resistance. That is other things like skin tags, lipodystrophy, and others. And other system examination were normal. Abdomen, as the patient has history of pain abdomen. Patient has non-tender, no organomegaly, no palpable mass lesion. And in the testicular volume, P1, and the pubertal grading, because the patient presented around puberty. So P1, testicular volume is 2 cc, axillary hair is absent. So patient is not yet reached the puberty. At presentation, fasting sugar is 133, 131, postprandial is 290, HbA1c is pretty high at 10, and serum anti-TTO levels were 72, that is positive, and 90-minute post-meal CP peptide, which is actually test for insulin range, is 2.82, corresponding to the venous plasma glucose of 259. Tested as achieving the glycemic control, because we wanted to see that inherent internal insulin capacity and CBC, lipid profile, liver, renal functions, urine SCR, TSH, FT4, electrolytes, all were tested and within acceptable range. Even the amylase lipase, because of the pancreatitis, was also within normal range. Serum CA and CA 19.9, because the pancreas is involved, is also normal. When you do the imaging, then we do find that the USC abdomen was initially diagnosed. It did show that atrophic pancreas with calcific foci in the head of the pancreas. CT abdomen also did mention that the presence of multiple calculate foci present both in the parenchymal as well as intraductal. So it is disease pathology, but also within the parenchyma of the pancreas, and also there is irregular dilated main pancreatic duct, that is 6 millimeter. We understand how quite big dilated it is, suggests that chronic cystic pancreatitis. So this is a classical presentation of chronic pancreatitis with cystic degeneration of the pancreas, and MRCP is also done. Did not show additional information or any blocks or any obstruction in the enzyme secretions. So coming to the why we need to discuss presentation, because classically this patient presented in the age of type 1 diabetes, presented like type 1 diabetes with very high blood sugar. Father has a diabetic and died early even in the insulinopenia, but again, diabetes typically usually develops several years after the diagnosis of chronic pancreatitis. That is the normal learning we get. But unlike in adults, that is the point of learning, that when the type 3 diabetes affects significant proportion, we commonly see the pancreatic diabetes in adults, but only 4 to 9% children with acute or recurrent pancreatitis or chronic pancreatitis experience type 3 diabetes. That is highlighted greater regenerative capacity of the pancreatic tissue in the children. So that is the difference from the adults with the children. That is in the current diagnostic criteria of type 3C, which shows the objective evidence of exocrine pancreatic insufficiency, characteristic abnormality of pancreatic imaging, as we discussed, and absence of autoimmune markers typical of type 1 diabetes. That is which is different in our case. However, mounting evidence of large database suggests that 25% of type 3 diabetic children, especially the children we are talking about, they have a test positivity of islet antibody. So it is a mixed picture of presentation, and if we go for the diagnosis and the presentation of the type this kind of diabetes, we definitely find that these diabetes actually have a increased autoimmune response to the pancreatic tissue and increase the risk of destruction because of autoimmune destruction. So it may be linked somewhere, and however, the present case of type 2 diabetes, type 3 diabetes, which we are discussing, has a positive carrier antibody we have discussed before, and unique opportunity to investigate the emerging role of pancreatic autoantibodies in the pathogenesis of type 3 diabetes, as we must have been understanding before presentation that there is a link of autoimmunity and at least a link of inflammation and immune response in the chronic pancreatitis. So that may be associated with chronic pancreatitis as well. So maybe the autoimmunity indirectly linked with the chronic pancreatitis. The remains conjectural whether the islets antibodies contribute to the pathogenesis in this patient autoreflex epiphenomenon secondary to pancreatic acid damage. So we understand it can be either a cause and an effect. So cause because the autoantibodies can destroy the pancreas and precipitate the pancreatitis, or as because there is a partial destruction of the pancreas, the acinar cells were destroyed, the antibodies antigens were released, and body then started developing antibodies against the pancreatic islets, and that develops the anti-antibody or other antibodies possibility. Strong families of pancreatitis should include the hereditary pancreatitis, as we can see in this patient. That is a different group of presentation, and we need to exclude certain genetic studies like PRSS1, PRSS2, SPINK mutations, TRPSN, and CFTR. And as we have seen, the cystic fibrosis is one of the very common presentation of pancreatitis and the diabetes as well. So we should be looking for this association in these patients. So this is a unique opportunity to find out whether the autoimmunity in the chronic pancreatitis with diabetes can be the cause or the effect of the autoimmunity causing the pancreatitis itself. We need further studies and then the group trace analysis and the islet cell behaviors, maybe the culture studies as well, cell culture studies. So the genetics are also important from this study, this case presentation, because this patient had a family history of pancreatitis and which father died quite early age. So to conclude, the unique understanding of the age-old relation, interpreting case results only within the inappropriate clinical context. So we have a normal presentation of FCPD quite middle age or in the later young age, but in this patient at the age of 11, the patient can present, and presence of autoantibodies can confuse us when we need to exclude the other causes as well. As we have said, the positive pancreatic antibody can be present in the type 3 diabetes, so it does not exclude the presence of pancreatitis or type 3 diabetes, and should not be used to exclude the diagnosis. So that is the learning point in my understanding from this case study. The patient present to us, at present the patient is fine with the insulin and the good glycemic control, and pancreatitis is not aggravated, but patient did not require surgery at present. So this is one of our case presentation in IGM published. So maybe I'm sorry for the delay and the glitches we had today, but this is the end what I can say. But any questions and any discussion is welcome. Hello.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge, the case study which you have given, will be definitely going to help all the participants on their practice also, sir. Sir, there is a one feedback from Dr. Subrata Das, and he has written well explained case study. Thanks for discussing.
Thank you very much. And I'm again sorry for the glitches, which I had to start late because of the
Yes,
sorry.
sir, totally understand, sir. Not a issue, sir. And sir, I can see there is no further questions, sir. With all your permission, shall we conclude this session for today?
Thank you very much for your time as well. Thank you very
No
much.
problem, sir. And we would like to see you in future also with different topics, sir. Till then, take care of yourself, sir. Thank you so much for joining and making the session informative one. Thank you.
Okay.